strokes. Probably one of the more common neurological emergencies that you guys are going to run into out there in the field. What is a stroke? If you guys had to just describe to a family member what a stroke is, how would you describe it?
The brain is not getting oxygen.
Lack of perfusion of the brain. Family member's going to look at you like you're nuts. I have no idea what you're talking about. But it's really coming down to oxygen, right? The brain is not getting enough oxygen, and that is because it's not getting enough blood. So what is our goal? What's our goal in any kind of a stroke patient?
Early recognition.
Exactly. So the goal is you guys need to recognize early. Right, early recognition. So over the last probably 5 years, we've seen paramedics have a much larger role in recognition of strokes. We've seen a lot of hospitals specialize in stroke care, and that's changed our protocols. That's changed how we go about treating our stroke patients. They've given us guidelines. It's no longer just throw them in the back of the ambulance, put them on high-flow oxygen, and rapid transport. Right? We're not doing a whole lot for our patients when we just do that. We need to recognize it, and we have some tests and stuff that we can do in the field that are going to dictate whether they go to the closest hospital or they go to a stroke receiving kind of facility. So early recognition is the goal. With the added bonus of early intervention. So intervention at the hospital is going to take two forms. It's either going to be some sort of surgery to evacuate bleeding with putting pressure on the brain, or it's going to be given thrombolytics, fibrinolytics, those kinds of medications. As far as the pathophysiology goes, these signs and symptoms are usually either from emboli or aneurysms. So when you think of an emboli, what is an embolus?
It's a clot.
It's your blood clot, right? It's something that's blocking it. So these are sometimes called sometimes these are called occlusive, like an occlusive stroke. What about with an aneurysm? What is an aneurysm?
It's a breach in the vessel ruptures.
Okay, vessel ruptures, some sort of a breach. In its basic terms, it's a weak blood vessel. As that vessel becomes more involved with the pressures and stuff that it's dealing with, that weakness becomes greater and greater. When you think of aneurysms, probably the best visual that you guys have had so far would be something like an aortic aneurysm. How many layers do our blood vessels have?
Maybe 3 or 4.
They have 3 layers. When we look at these layers, we have 3 or 4. All right. So you've got 3 layers. This first layer, the outermost layer, is going to be called the tunica externa. You've got another layer, which is your muscular layer. That's the tunica media. And then an internal layer, which is your tunica intima. Oftentimes what happens with these aneurysms is it's either just a congenital defect where there's some thinning or some weakness that's already here. The other times, the majority is we'll have some sort of a clot that will attach itself to the wall of that vessel. And as that turbulent blood flow is moving through this internal part, what's this internal space called?
Intravascular space. Lumen?
The lumen. It is the intravascular space. As it's moving through that lumen, it can actually cause that clot or this piece of plaque to rip away. And when it does that, it can actually tear the internal side of that lumen, creating a weakened area of that blood vessel. When that happens, you can actually have blood get between the layers. And as that happens, think of it like Swiss cheese. It'll actually start to separate those layers apart. As those layers begin to separate more and more, that weakness becomes that much greater. And eventually, you can end up getting rupture of the vessel itself. If that happens in the brain, what kind of stroke is it? It's a hemorrhagic stroke. So you get a hemorrhagic stroke. If we were to get something like this in our aorta, and that ruptures, right, it's an aortic rupture from an aortic aneurysm. So that's your AAAs. The pathophysiology behind it is the same. What is the number one cause of hemorrhagic strokes?
Hypertension.
Exactly. Hypertension. Which is why as we get older, a lot of our patients end up being put on antihypertensives to try to control the pressures that are within the vascular space of the brain. Yes, sir.
Is there a hospital treatment for hemorrhagic stroke?
Usually surgery. A lot of hemorrhagic strokes. So here's what they're going to do. When you encounter a stroke in the field, can you definitively say one way or the other whether it's hemorrhagic or ischemic? There's some signs and symptoms that we can kind of associate with one or the other, right? But for the most part, we don't have a portable CT scan. So the first thing you're going to do is when you recognize the signs and symptoms of that stroke, you're going to notify your base hospital. You're going to put out a stroke alert saying, hey, I believe I've got a stroke. These are the signs and symptoms. This is what I've done. And they're going to take them to that particular hospital. The very first thing that they're going to do is they're going to have them go through a CAT scan. They're going to have that computerized tomography scan in order to determine whether or not it's hemorrhagic or ischemic. Because that's going to determine what their next course of treatment is. So if it's a hemorrhagic stroke, how is that going to show up on the CT scan? You guys ever seen this?
It's going to show up as a white area?
It's going to show up as a white area. Now, is blood usually found free-floating within the brain? It's not, right? There's vessels within the brain, and that's where blood likes to be. Your brain does not like to be in contact with blood. So when that happens, you end up with all kinds of other issues that the brain starts to contend with. But as that bleeding continues on, it has to take up space. It's not in the vascular space, so where is it going?
That third space.
It's going all around the brain tissue, right? It might be localized to where the bleeding is, and you end up getting a hematoma, right? And as that does that, that pressure is going to start pushing down the brain. You saw from that video, that doctor could just kind of roll that brain around in her hand. It was very squishy, right? So it'll displace very easily. And as that brain tissue displaces, it's going to affect those neurons, right? So when that happens, now we start seeing a lot of the other signs and symptoms that we see with stroke, which I will get to here in a second. All right, so number one cause of hemorrhagic stroke is hypertension. Yes, sir?
So is a hemorrhagic stroke, does that usually come on slower than an ischemic?
You know, it really depends. It really depends. Sometimes it depends on the blood vessel. If it's a smaller blood vessel, it can come on slow. If it's a larger blood vessel and it's able to bleed quite a bit more, it'll come on really quickly.
Okay.
Depends on the volume of blood that's actually evacuated into that cavity. So with our hemorrhagic strokes, this is bleeding into the tissue. So in our ischemic strokes, like I said, these are sometimes called occlusive. Because unlike a hemorrhagic stroke where you end up with a tear or something in that blood vessel, in an ischemic stroke you actually have complete blockage of the lumen of that blood vessel. So what gets affected in an ischemic stroke? What part of the brain?
The part distal to the...
Exactly. Everything that's downstream or distal from where this occlusion takes place is now no longer receiving blood. But is that exactly the same thing that's happening in a hemorrhagic stroke, potentially?
Yes,
Right? Blood still isn't getting down there, but in a hemorrhagic stroke, you have that added, pressure and just the blood itself coming into contact with the brain tissue. In our ischemic strokes, you have complete blockage of everything downstream from that clot. What other organ do we see this kind of injury in? In the heart, right? So the pathophysiology of an occlusive stroke or an ischemic stroke is exactly the same thing that's happening with our myocardial infarctions, right? Everything that's distal from that clot is no longer receiving enough blood, which means it's not getting enough oxygen, which means that tissue becomes ischemic. After a while, that tissue, not getting oxygen, is going to revert to what kind of metabolism? Anaerobic, right? So it's going to start to produce all kinds of toxic byproducts, lactic acid, that kind of stuff. As that continues along, and it's not able to generate fuel for itself, it becomes a dye. And what do we call tissue that's dead? It's infarcted tissue, right? You have an infarction. Exactly the same thing. So what is the biggest thing that we need to do along with our recognition?
Rapid transport.
Rapid transport, the biggest thing is time. All right? We are not going to spend a whole lot of time on scene trying to get a good history, trying to ask them if they can follow directions. You need to do a very quick, a very rapid exam on these patients. If you are suspecting that they're having a stroke, you need to find out when they were last seen normal.
I was going to ask, so there's someone just be like, as best you know, when was the last time this they were not beat or whatever?
True.
I had a better, it sounded more better in my head.
I hope so, because I thought I was having a stroke. Couldn't understand it.
I think this camera's on.
Yeah. So the biggest thing is finding out time. So what is our time frame in general that we have?
Convoluted therapy.
Yeah.
3 to 4 hours. 4.5 hours.
Every stroke center and every county is going to have slightly different protocols on it, but generally, you've got 3 to 3.5 hours from onset of symptoms. So it's really important to find out when they were last seen normal. Can you do this in a patient that's by themselves? Maybe. You ask them, hey, when did this start? Right? They might be able to talk to you, they might not. They might be able to write it down. If you can't figure it out, the doctors are not going to look at alternative therapies for them. And even if they are believing it to be a ischemic stroke, they're still going to get a CAT scan to rule out hemorrhagic. Because if they do give them fibrinolytics and they're having a hemorrhagic stroke, it's going to kill them. So really important that they get that scan done fast. I don't know how you guys do it up here, but in all the stroke patients that I've had over the years, a lot of times they don't even come off your gurney. You go straight to CT. You'll take a nurse and a tech with you, and you go straight to the CAT scan. Yes, sir.
So we talked about with like the aortic aneurysms, the aortic arch is like a very turbulent area, so that's where like the deposits of stuff get deposited, leading to an aneurysm. But are there certain areas in the brain that are really turbulent, similar to the aortic arch?
Probably not as much, because the vessels aren't that big, but you do have arteries in there. You have very large arteries. Remember in that video where she turned it over and showed you the cerebral arteries that were running down through it? Some of those can be as big as your pinky. So they can be very large arteries that feed the brain. It really comes down to the majority of the aneurysms and the hemorrhagic strokes that we have are due to the weakened blood vessels. It's something that happens with age. It can be something that's congenital.
And those are usually just random spots.
Just random spots. So if they happen to do a CAT scan, they do a dye. They'll do a contrast dye. They can actually look at the vessels of the brain and determine whether or not you have aneurysms. But they have to specifically look for that. Okay, it's not something you normally get on your regular physical exam that these patients will have annually. So they have to look for it. So kind of like what was mentioned earlier with our ischemic strokes, the damage that's done is really going to depend on what artery is involved. And this is for both hemorrhagic and ischemic. But the larger the artery, the more brain that blood vessel is going to supply blood to, the greater the signs and symptoms that we're going to end up seeing as that ischemia progresses. Can't say this enough. Time is imperative. Right? So, you guys heard time is tissue? Right. Very true with our strokes. It's the same thing with our MIs. The sooner we get them to definitive care, the better their outcome is for survival. We're not in the business just to take people to the hospital, but we're there to get them to the hospital so that they can actually walk out of the hospital on their own. So this is where you guys have to use your clinical judgment and your knowledge of differential diagnosis, which you guys will hopefully get a little bit of a taste with when we get into ANLS, to rule out other things. Because not every sign and symptom that we associate with stroke comes from a stroke. There are other things that can cause that, and you have to kind of rule in or rule out certain things. So when we look at the pathophysiology of our hemorrhagic strokes, we kind of already talked about that a lot of it is just the bleeding into the direct brain tissue. But what is the biggest thing that we talked about when we're dealing with bleeding inside the brain? What do we have to worry about? ICP. All right, so our intracranial pressure is what we have to worry about. As that pressure increases, the function of the brain itself starts to decrease. And the larger that bleeding lesion becomes, the more function that it starts to affect.
Thrombolytic therapy, that time frame, is that because of there's like too many, with crushing injuries, you have to like administer sodium bicarb and stuff to neutralize all the weirdness. Is that
Where this number comes from is they've done studies, they've done statistics, and as you start to progress past that 3-4 hour mark, the risk versus benefit starts to become unbalanced, and they have a greater chance of not receiving brain function back, which is really what we're going for. As those areas of the brain become hypoxic, become ischemic, and eventually end up dying, reperfusion by giving a fibrinolytic is not going to increase their ability to have any kind of functional return. So what is the biggest, probably the biggest issue with giving a fibrinolytic to our stroke patients? They can cause them to bleed. And it may not necessarily be bleeding into the brain, but if they've got any other kind of internal injury, it's going to thin their blood and it's going to cause them to bleed. So that's the huge risk to giving these fibrinolytics. So what is the one fibrinolytic that we hear the most about? TPA, right? So with TPA, 3 to 4 hours is about the most that they'll allow. Some places, depending on their neurosurgery ability, they may extend that out to 6 hours, but most places it's generally 3 to 4 hours. Yes, sir.
A couple questions on that. Is the different protocols based off of how much you want to take the risk of it, as well as the time? Is it more of an issue of they've already lost this much brain already, it's not worth the risk, or it's more effective when we do it early?
It really comes down to the research that they've done, the statistics that are available to them, not only in their local area, but within kind of the world of healthcare, and who's running the neurosurgery department and what they feel the protocols are. So they'll pass on those recommendations to like a county EMS system, and they'll say this is what we want in our county as protocols in order for them to come to a stroke center. Now, as far as TPA, that's going to be completely dependent upon the neurologist or the emergency room physician on whether or not they feel comfortable giving it. But for us, this is the window that most protocols will allow us, within 3 to 3.5 hours. Now, how accurate do you think that time really is? When was the last time you ever seen normal? I don't know, a few hours ago? Okay. Well, I went to the store, and then I went to the bank, so that couldn't have taken more than a couple hours, so probably about 2-3 hours. So you're getting a guess. And so those doctors have a little bit of probably some wiggle room that their experience allows them based on the overall health presentation of that patient as to whether or not they want to go past this. But for us, most of the protocols, like I say, is between 3.5 hours, and you'll go directly to a stroke receiving facility. Outside that window, a lot of times we get them the next day. And you'll ask the caretaker, well, why didn't you call us when this happened? Well, they didn't want to bother you guys. The patient didn't want us to bother you. I thought it would get better, right? That kind of thing. And it'll be sometimes a day or 2 days later. Way outside the window, they're not going to do fibrinolytic therapy on those patients. That's just kind of the nature of how that we end up in the middle of that. All right, so I want to talk about ICP. So intracranial pressure is the pressure that's naturally inside of our brain. We do have a normal pressure of 0 to 10 millimeters of mercury at any given time inside of our brain. Whenever we have any kind of trauma, or in the case of a hemorrhagic stroke, we have bleeding that enters into the brain and it causes that pressure to increase, there's things that we can visually inspect through vital signs that kind of tell us that. So the other thing in here is we've got this thing called CPP, which is cerebral perfusion pressure. Cerebral perfusion pressure is how much pressure those blood vessels inside the brain need to have in order to perfuse the brain tissue. This generally is 70 to 90 millimeters of mercury. So when we measure cerebral perfusion pressure, we get this thing called mean arterial pressure minus ICP. So mean arterial pressure is the pressure the systolic blood pressure that's within the arteries itself, that's going through the vessels. As our ICP increases, what does that do to our overall cerebral perfusion pressure if we don't change our arterial pressure? Right? As this gets bigger, right, let's say that this number is 70, and I've got a mean arterial pressure of 60, and our normal ICP is 10, that makes sense. This is actually giving us, actually if I said that this was, let me do this 80. There we go. So if this is 80 and that's 10, that makes sense. Not a big deal. So what happens if my ICP shoots to 50? What does that give me for my
30?
Right? 30. So now I've got a cerebral perfusion pressure of 30, which is not going to be enough. So when we think about patients that are hypotensive, what is the magic number, though, that we're really concerned about when their blood pressure gets too low? How about lower than that? How about 60? Right? When we start getting patients whose blood pressure is 60 or less, that's what we're worried about. Are they perfusing their vital organs? Right? We know at 90, we're into that hypotensive state. But it's when we get those patients that are down into the low 60s that we're really concerned about that. That's when we start flooding them with fluids, trying to increase preload and intravascular volume to increase that blood pressure. So, looking at kind of how those numbers play a role, what needs to happen in order to get this number back up to 70 or 90?
Increase the mean arterial pressure.
You need to increase your arterial pressure, right? So let's say we increase this to, I don't know, 150. Now we've got a cerebral perfusion pressure of 100, right? What happens if our ICP is 100?
Oh, shit.
Right? Now we're starting to have to go, what, 180? Just to get that arterial pressure to be able to perfuse the brain. So what do we see in our head injury or our hemorrhagic stroke patients?
Cushing's triad hypertension.
Well, you're getting ahead of me there, but hypertension, right? So you'll see that 230 over 140 kind of a blood pressure, all right? Now, what else do we see? This is our blood pressure. What about our heart rate? You're going to see them bradycardic, right? So I'm just going to say 40s to 50s, somewhere in there. And why are they bradycardic?
Because the brain recognizes that, well, the brain has like being pressure because of the ICP, and also it recognizes that if it has a high heart rate, it'll just increase the blood pressure.
All right, so you've got competing things going on, you guys, right? You've got the brain's desire to maintain perfusion. So what does it do to ensure that it has perfusion first? It's going to raise that blood pressure, right? So you remember, basically cardiac output, stroke volume times heart rate. So in order to maintain that blood pressure, we got to increase stroke volume. So we're going to increase our blood pressure to maintain our cerebral perfusion pressure. On the other side, you've got these baroreceptors that are saying, hey, our blood pressure is too high. How do we lower blood pressure? We're going to lower the heart rate. So by lowering the heart rate, we're lowering the blood pressure. But you've got two competing mechanisms. So what you end up with is a hypertensive bradycardic patient. What should you never, never do to these patients? We're going to get to that.
Fluid. Give them oxygen?
You can give them oxygen. We'll talk about how you titrate oxygen. But let's just look at this number here. Okay, atropine. What is atropine going to do to our patient who's got a heart rate of 40 or 50 in this particular instance? Right? If I artificially increase my heart rate, what is that going to do to my cardiac output? What is that going to do to my systolic blood pressure?
Raise it.
I've got a patient that's got 230 systolic blood pressure. Am I going to pretty much have them rupture vessels in their brain even further? Right. So atropine, do not give, and transcutaneous pacing. Please, please, please don't pace a bradycardic patient who is hypertensive. All right? Because what you're going to do is you're going to increase cardiac output, and that's going to increase systolic blood pressure, which is going to make our hemorrhagic strokes even worse, or our trauma patients even worse. I bring this up because this has happened in the field. Okay? Your book even says in bold letters, contraindicated. Right? The big thing is recognizing these signs with a respiratory pattern that is altered. Right? And what do we call those three things? Raj already mentioned it. This is Cushing's, right? All right. Please recognize Cushing's triad.
So it's bradycardia, hypertension,
And some sort of altered respiratory pattern. So, what is the one that we kind of talk about the most when we start talking about increased ICP? Chain soaks, right? Where you get this progression of kind of a rapid increasing respiratory rate, which follows with what? Gets faster, 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 they stop. So you get that it's a winky bog of breathing, right? You get that apneic period, then the respiratory rate starts increasing again. And kind of like a roller coaster, drops, goes up. So in order to really assess this, you have to be watching them for some time. This isn't something that happens every 15 seconds. This can take several minutes. So when you initially check their respiratory rate, what do you guys do? Sit there and you look, listen, feel, whatever for 15 seconds, multiply by 4, and then look at it again in 5, 10, 15 minutes, right? You're not going to catch these patterns. So what's a great way to document our respiratory rates and patterns? What's that? End-tidal capnography. Put that end-tidal cannula on them. And one, you'll have a record of it. And two, you'll actually notice that respiratory rate changing every time you look at the monitor. So that's a good way to notice that. So I mentioned the tentorum, the foramen magnum. There's also another one that's called the tentorum. I'm just going to say the foramen magnum. And there's one more which I'll get to. So this is herniation. So when you deal with herniation, it's just an increase in pressure amongst those tissues that causes that brain tissue to be displaced across that tentorum or down through the foramen magnum. Once that happens and you have herniation, that's it. It's game over. The patient will die. So our goal is to prevent herniation. So when we're preventing herniation, what are some things that we can do?
Positioning.
Okay? Position them. Let's put them at a 30-degree angle. Their head up at 30 degrees. So we just put them in like a little semi-fowlers.
Hyperventilation.
Okay, this is where we get to hyperventilate. All right, so when I say hyperventilation, we're talking, we want to keep you right at 20 breaths per minute, okay, or greater. Never more than 30, but you want to keep it right at that 20 to 24 breaths per minute. Why? What is that going to help us accomplish? Hold on.
It's going to get ideally our total CO2 to the high 20s, low 30s.
Who's that? Okay, so by hyperventilating, we're going to get our end-tidal CO2, and I would say 30 to 35 is a good range to shoot, but that high 20s, low 30s.
Doesn't oxygen create vasoconstriction too?
And that's it. So if my end-tidal CO2 is low, what does that mean my oxygen levels are? It's basically telling us we've got high oxygen levels. So we want to have our pulse oximetry 94 to 99. Okay, that's our target that we want to reach. So whatever you need in order to get that, whether it's an oxygen can or a nasal cannula or putting them on an artery breather, you want to shoot for 94 to 99%. Now, in hyperventilating, which is greater than 20 breaths per minute, that's going to cause cerebral vasoconstriction. Normally, in our stroke patients, constricting blood vessels in the brain is not necessarily a good thing. Because what are they already having an issue with?
Oxygen in the brain.
Right? Whether it's hemorrhagic or ischemic, the idea is that oxygen is not being delivered distal to wherever that injury occurred. And so by hyperventilating them or putting them on high flow oxygen, all we're going to do is cause vasoconstriction, which is going to further worsen their injury. So in our strokes that are not showing signs of Cushing's triad, all right, 94 to 99% with an end-tidal CO2 of 30 to 35 is where we want to keep them. If you need to give them oxygen, we're going to titrate that, usually using a nasal cannula. Now, if they're having difficulty breathing, just like any other respiratory patient, oxygen is a drug, titrate it to the amount that you need. Just realize that high flow oxygen is going to cause vasoconstriction, which is going to further the problem. Why is this okay in our impending herniations?
Because it'll kill the person.
They're going to die probably anyways. The idea is if we can vasoconstrict, what is that going to do to the tissue itself?
Allow more room for it to.
It's going to give it just a little bit more room, hopefully, in theory, to allow or to prevent herniation just long enough for us to get into the hospital where they can do either surgical intervention or go in with any kind of osmotic diuretics and things like that to try to decrease that ICP.
Can we also administer like 3% saline solution to draw out some of the fluid?
Think about it though. Is that something that you really want to do? In our strokes.
They're gonna die.
In our strokes.
Yeah, no.
So in like a trauma situation where there's swelling,
Yeah.
we're trying to remove the cerebral edema. All right. By doing this, we're basically going to dehydrate the brain, and we're going to cause further injury. So we don't really get that in our protocols to do because we still need to have a CAT scan. All right. So in our protocols at the national level, we do have options for osmotic diuretics. Do you remember the name of that medication? Mannitol, right? But mannitol is for trauma, for cerebral edema. We're not really giving it for our hemorrhagic strokes. So really, the only thing that we can do is recognize the signs and symptoms and rapid transport. All right? We can do some things like keeping them at 30 degrees, make sure that they're oxygenated appropriately, hyperventilate them if we're seeing signs of Cushing's triad. Otherwise, any ventilatory support that we give them should be at less than 20. Does that make sense? Susie, did you have a specific question that I can help you out with, or is?
Well, it kind of seems like we're going back and forth from whether or not to bad to.
I'm going back and forth, or just what people are saying?
And book too.
Okay.
I don't know. It says that you don't want to like decrease perfusion levels in values with vasoconstriction, but then that you want to decrease bleed.
You want to decrease the volume of the brain,
Yeah.
so that there's a little bit more space between the brain and the skull itself. That will help to decrease ICP. That's why the only time we're ever going to hyperventilate is if they've got the signs of Cushing's. This is telling you that they're impending herniation, and if we don't do something, they're probably going to herniate and die, and they're going to code right in front of you. So that's the difficulty when we start dealing with textbooks and different resources as what neurologists wrote it, what do they kind of prefer. Everything that I've seen in my experience is we're not going to hyperventilate. They kind of changed it from the hyperventilate, hyperoxygenate kind of terminology. Only in the cases of impending herniation are you going to hyperventilate.
So if you did have that case of impending herniation, would you contact the face first to hyperventilate, or would you start doing it and then say, hey, I'm hyperventilating this patient?
Me personally, I would just do it.
You just do it.
You know, because if you're starting to see these signs, they do kind of creep up on you.
Right.
But if you start recognizing these, you're already late. Okay. So at that point, start hyperventilating, and their respiratory rate's going to be all over the place, anyways, if they're even breathing at all.
Right.
So, what are we going to want to do with these patients? What kind of, if we're talking about a Cushing's triad patient, what kind of mental status are they going to have?
Okay. Altered for sure.
They're probably going to be comatose. Right? These are going to be your unconscious, unresponsive GCS and 3 patients. So what are we doing with these patients? We're going to intubate them. Okay. You may need to RSI them. Depends on how much vegetative control they still have. They may have trismus of the jaw because of that increased ICP. So you're going to have to look at probably facilitating intubation with paralytics and sedatives. All right, so that's going to be your Versed, your etomidate, right, succinylcholine, that kind of thing. So you got to keep that in mind. Because at this point, are they controlling their airway? Probably not. Just remember, though, the best airway for the patient is the one that works. So if you can get by with a BLS airway and you're able to control it, great. Otherwise, make sure that you intubate these patients. And that's going to give you better control of your end-tidal CO2. It's going to give you better control of your pulse oximetry as well, once we have that advanced tube in place. So what kind of assessment are we going to see on these patients? We already kind of talked about what we're going to see in terms of signs and symptoms according to Cushing's. But what other, in our basic strokes, what are we going to see?
Dysphagia and dysphagia.
All right. So right off the bat, you hit the big one that most medics, most doctors even sometimes, will have an issue trying to remember which one's which. So you start using a lot of these medical terms. So let's break it down into this. What's our basic assessment of a stroke patient? What are we looking for? The 4 things.
Facial droop.
All right, so we've got facial droop,
Arm drift.
right? You get your arm drift. And then, yeah, just the time, or when was their last time normal. So this is what they educate the public. You'll see billboards that talk about FAST. Every stroke scale that's out there, from the Cincinnati Pre-Hospital Stroke Scale, the Los Angeles Pre-Hospital Stroke Scale, they all have some component of FAST. So this is what we want to utilize when we're trying to determine if that patient's having a stroke or not. So you had mentioned, let's go to speech. You said aphasia, right?
Yeah.
So spell it.
So aphasia with an S is the inability to convey thought. Aphasia with a G is the inability to control your palate.
Totally just like completely stole my thunder. So, but as much as I like that, can you spell it, please? Which is what I asked.
APHSIA. Aphasia. Yeah.
Sure. All right. So he's absolutely right. So aphasia with an S is the one that we're dealing with speech. They both sound a lot alike. And then aphasia with a G is going to be basically that inability to swallow is really what it comes down to. So in doing your neurological assessment of these patients, we don't want to just limit it to facial droop, arm drift, slurred speech, and how long has it been. We need to dig a little bit deeper. That's going to make your assessment that much more thorough, and it's going to give credibility to why you're doing the decisions that you're making. So aphasia. So we need to recognize that they're basically having slurred speech. What else do we have in it?
Dysphagia.
Yeah, which is going to be just difficulty, right? So if we add DYS to it, that's going to be just your difficulty. So let's look at movement now. So what do we have to deal with when we're dealing with movement? What kinds of things are we looking for? All right, so definitely going to deal with our arm drift. We're looking for any kind of muscular weakness. What do we do, even from our basic BLS patient assessment? What are we doing when we come to each extremity?
CSN.
All right, so we're looking at pulse motor sensation. Do we ever do grips, pulls, and pushes? Right? Let's look that there's a reason why we're doing that. How, are they weak on one side? Do they have unilateral weakness? So we're looking for any kind of weakness. Unilateral, either paralysis. What is unilateral paralysis named? Right, hemiparesis. So unilateral paralysis or weakness. We're also going to be looking at their facial symmetry. Right? Is there any issues with the symmetry of their face? That's where we get that facial droop. So when we're having a stroke and the muscles that are controlled by that area of the brain are no longer basically in contact with the brain, they relax. And so you'll end up with no muscle tone in that affected side. You're also going to see your arm drift. So what do we call a droopy eyelid?
Lazy eye.
Lazy eye. It's called ptosis. P is silent. That's just a fancy term for drooping eyelid. In case you come across it on a test, you know what it means. Can we assess a patient's ability to walk? I mean, should we in our stroke patients say, get up and take a few steps for me? They fall down. Probably not a good idea. You can do your grips, pulls, and pushes. But if they're having difficulty walking or unable to walk, we call that ataxia. The other thing that you want to do is look at their tongue and see if there's any deviation. And it's not necessarily can they move their tongue side to side, but if they are having a stroke, they lose part of that muscular control of their tongue. The other side is going to basically pull it to one side, so they'll stick out their tongue, but it goes to one side. So it's kind of like the tongue version of a facial droop. All right, sensory. What are some things that we can address with our sensory? How many senses do we have? 5, 6, right? Some 7, right? Depends on who you talk to. So what is paresthesia? Right. This is the pins and needles. Right? You guys have all felt paresthesia probably once in your life. But your leg goes to sleep, your arm goes to sleep, and when it starts to come back to life, you start feeling those pins and needles. That's paresthesia. So somebody that's having unilateral paresthesia, that is something that we want to document. How about any kind of blindness? So how do we assess somebody's vision in the field? Do we have to sit there and hold the chart and say, read the lowest line you can read? I think you can do something like that. I just ask them, hey, any blurred vision? How does your vision look to you? You kind of do the best visual acuity that you can do in the field. You can ask them, hey, can you read this? But I usually ask them. So if you ask them if they have any blurred vision, what other questions should you probably preface it with? Do you wear glasses? Because if they wear glasses, you didn't grab them, they'll say, yeah, my vision's blurry. All right? So now all of a sudden you're like, hey, they've got double vision, they've got blurred vision, and you just realize that you left their glasses at home. So make sure that you find out about their normal vision state. So what is cognitive? So somebody's cognitive ability.
How smart they is.
This is any note time before?
Yeah, they're altered.
This is just their ability to think, their ability to understand what's going on around them. All right? Every one of you in this room right now has probably a little bit of mild cognitive impairment because you're tired of listening to me talk for the last hour. But this is just their cognitive ability. This is what makes them them. So how do we test somebody's cognitive ability? You kind of already mentioned, I think it was you.
Any note time before.
Right. We're going to find out what their level of consciousness is. Right? Are they alert-oriented person, place, time, and event? If that comes back as a deficit, you need to follow that up with hopefully somebody that knows them. Is this their baseline? Is this normal for them? We see this a lot in our dementia patients. So you don't want to take somebody to the hospital when you're expecting them to have a stroke and really they just have a little bit of a bad day with their dementia. Okay. So you got level of consciousness. Is it safe to say that this could also be considered confusion? Right? This isn't normal confusion. They're confused. Right? They can answer your questions, but they just don't really know the answers. What is something that you have to worry about with strokes, specifically with our hemorrhagic strokes?
Projectile vomiting.
All right, so nausea, vomiting. Right? What else? You're on the right path there.
Bloated pupil.
Bloated pupil? That's a new one. I'm gonna say you meant blown. So what's another word for blown?
Dilated.
Dilated, all right. Call this dilated. All right. So yeah, so you have your dilated pupil. So it's real easy to skip over this in our assessment, you guys. You got to check the eyes. All right. You have to look to see what their pupillary response is. If they are having a hemorrhagic stroke, this is going to typically be one of the later signs. So you definitely need to assess that. So we get a little bit of nausea, vomiting over here. How about seizures? Okay. Probably the biggest one. Any head injury, any brain injury in terms of stroke, you have to always consider that they might possibly have seizures. You also need to ask yourself, which came first? Right? Did they have a seizure and now they're confused? Or were they confused and now are having seizures? It's really going to lead you into kind of what caused what. When we're looking at hemorrhagic strokes, this is the number one cause. What's the number one complaint?
Headache.
Worst headache of their life. And we'll say that to you. Worst headache of their life. So when you're trying to determine whether or not maybe this is hemorrhagic versus an ischemic stroke, one, the presence of a headache. Two, the fact that they're really hypertensive is going to probably lead you down the road that they're probably having a hemorrhagic stroke. Do we treat them any differently than our ischemic strokes in terms of our field treatment? We don't, right? ABCs, oxygenate appropriately, rapid transport to the appropriate facility. That's what we're going to do. So seizures. We're going to talk about this as its own neurological emergency, but if we're concerned about this patient having seizures, what should we probably have ready? Some sort of benzodiazepine, right? To be able to counter that seizure. Depending on how bad this is, you may not be able to control that seizure with benzos. So what else would you need to think about in terms of our national scope of practice? Paralytics. You can basically paralyze them out of that seizure. But here's something that a neurologist once told me that made a lot of sense. So we give them Versed, we give them these medications to stop the seizures. A lot of times we're just seeing the physical cessation of those seizure activities. They're still having seizure activity in the brain. So when we have these rapid firing of these neurons, what do they use to communicate between each neuron? The neurotransmitters, right? And if we're just constantly firing these things, can we run out of neurotransmitter? Absolutely you can. We're talking about seizures that last like 30 minutes. That's where the real danger comes from. Not necessarily the hypoxia from the 2 minutes that they weren't breathing as effectively. It really comes down to the brain having basically chemical damage to itself from the loss of neurotransmitter. So those are ones where you use paralytics to try to stop that seizure activity. So you've heard like a medical-induced coma. That's exactly what we're doing. We're stopping pretty much every motor activity coming out of that brain.
And with that,
What's that?
you have to innovate at that point.
Oh, absolutely. Yeah. If you're going to use paralytics, you're going to innovate.
Wouldn't that also be helping the patient by decreasing the O2 demand in their brain, therefore helping them stay alive up there longer to get to
I mean,
the hospital?
theoretically, absolutely. But do we have any real way to monitor if our paralytics are successful? And is there a risk to using paralytics in patients?
Of course.
Right?
It'd be cool to be able to do that.
So paralytics are really going to prevent the
necessarily the neurotransmitters to the regard that you're thinking, but the seizure activity itself that's going on with the firing of those specific neurons that are controlling muscles. Okay?
It was blocked.
So it's not just the paralytics, but it's a combination of the paralytics with the sedatives like your benzos, and there are other sedatives that we don't have, like barbiturates and things like that. Good? All right, well, you started talking and then you stopped, so.
Well, that would be like it blocks the acetylcholine receptor
Right.
from doing it. Okay.
So it's gonna help stop that seizure. It's nothing that we're gonna really be able to deal with, but the idea is that if you can't control that seizure with benzos, you're gonna have to use paralytics to get them to stop completely.
And that we can do in like most civilian EMS protocols.
Right.
And it's different from RSI.
Exactly. Well, I mean, you're RSI. That's how you're getting them to stop seizing, but you have to continue that. All right, so that's our cognitive effects. Any kind of cardiac effects from having these strokes?
Yeah.
Yeah, tell me about it.
Increased blood pressure.
All right, so pretty much we already kind of hit on them when we talked about Cushing's, right? The biggest thing is the bradycardia.
Maybe a decreased preload or venous return.
That's what happens when these boys work and try to ride over it. Yeah, so the biggest thing that we have to worry about is the bradycardia that's associated with it. Remember, we're not going to use atropine, we're not going to do transcutaneous pacing on these patients. So management is pretty much going to be the same. If possible, 30-degree for the head. If you're considering any kind of cervical injury, then obviously we're not going to do that. Just do your best to try to maintain that open airway. Yeah.
That, like you want their entire back?
Yeah, you can just sit them up. Yeah, you're just sitting up the head of the gurney. Yeah. Now, I mean, you could do that.
I was thinking like, do you prop it up with a pillow an extra 30 degrees?
No, you just lift them up, just so that their head. Basically, the idea is that it helps to facilitate venous return back to the heart, but not so much that it's going to cause increase in pressure. So that's what your book suggests. That's the only reason why I'm kind of really bringing it up. You want to sit their head up just a little bit.
On a backboard, can you just tilt it?
You can tilt it up a little bit. So if we're dealing with airway, and we already kind of mentioned it with nausea, vomiting, what do we need to be prepared to do in these patients? Intubate. Okay, we already talked about the suction, right? All right, so we're going to suction these patients. What does vigorous suctioning potentiate? Kind of all of those, and the biggest one is vigorous suctioning can potentially raise ICP. Same thing with intubation. You guys can actually increase intracranial pressure just by intubating. Vagus nerve travels right down the back of your throat. You start basically getting in there with your laryngoscope or with your suction catheter. You can stimulate that vagus nerve that can cause an increase in ICP, which is kind of bad if we're already dealing with our increased ICP from a hemorrhagic stroke. So you just got to be real careful that you're not going to overstimulate them. Yeah.
Isn't it better than if they were to get to that point of vomiting now and including their airway to just have them intubated?
Yeah. I mean, if these patients are alert and oriented, right? It's just saying don't get in there and go to town. You know, just be real cautious with it. I would suction them just like you would any other patient. But if you are having to get to the point where you're suctioning vigorously, probably should just go ahead and intubate them anyways.
That's why they put the lidocaine, or you just put the lidocaine on them too.
So usually they use like a hurricane spray. If you guys have ever seen that, it's what's called hurricane spray. It's a type of lidocaine.
Would you prefer to go with the supraglottic airway as opposed to the intratracheal airway just to prevent further ICP?
I think it's a judgment call. Whatever you're more comfortable
Would
with.
the supraglottic protect it from the vomit?
Not as well. You know, I've never had an issue with the supraglottic airways.
Just like the other airways.
Well, I mean, it sits on top of the glottic opening, right? So there's always that potential that some of that emesis can get around the distal end of your tube, but it's better than nothing. I think if you're having to do something real quick, supraglottic airways drop very quickly and very easily. So I think you'd be okay with that. All right, so we already talked about you got to watch procedures. And just maintain our O2 stats. So what do you want O2 stat-wise?
94, 99.
94 to 99. That's going to be the best numbers you can get. So if you're getting 100% oxygen out of these patients, either no need to give them oxygen or titrate it back down because you're probably giving them too much. All right, I think we're good on that. All right, why don't you guys take a quick break, and then we're going to go over the stroke scales when we come back, specifically the two different ones. You all right, Aaron? You all right? Is this better than PowerPoint? Yeah. Spent a couple hours last night and a couple hours this morning.
This is awesome.
Yeah, it's one of those things you don't need a whole lot of pictures.
To your area, respective area, what yes, great breakout is now begun. Hold on. I guess what's going on that wasn't too. I was like, this is fucking hell,
This is the grill.
What's up with the early stroke notification you're talking about with the last one, that was 4.5 hours. Well, what's up with the blood level greater than 70?
What are you looking at?
I'm looking at my kind of protocol.
Okay. Because you just want to make sure that the reason that they're altered isn't because their glucose levels low.
Okay.
So anytime you, what's that?
Just rolling.
It's just one of those things. So kind of think of it as like H's and T's for ALOC, right? Remember, what's S and A are your tips? Seizures or strokes or whatever, right? So you want to make sure that the reason for their being altered isn't a hypoglycemic issue, that it's actually a cerebral issue. So check the blood sugar. But I've seen that in every protocol, which means that it was probably an issue at one time where people were thinking they were having strokes.
Yeah.
And they bring in a patient that's got a blood glucose level of like 20. They didn't treat it. They're having seizures. I don't know what's going on. Blood glucose is 5.
What's your first call? You're like a paramedic for 3 days.
Yeah, I wasn't kidding though when I said that pacing ICP actually happened this year.
Is that what the investigation is about?
What's that?
An intern or what?
I'm just going to leave it at that it happened this year.
I can see that happening.
But it was a trauma transfer with a head injury. The guy had a gunshot wound to the head.
I wouldn't even think of pissing anybody.
That's the completely wrong one.
So I'm sure that once they started pacing them and blood started squirting out a hole in the head, they were hypertensive, bradycardic, and
Did they miss the gunshot wound? Or?
no, they took them from the hospital because they had
vital
gunshot.
signs?
They were taking them to a trauma center. What's that?
I said they missed their vital signs.
I wasn't a part of it. I have no
Is that
idea.
what you're doing the conference call? Or
No,
That's
this is
what
for
the
something else.
investigation
This is
is.
actually for something else.
Oh,
is that for the guy pushed
No.
for SEDS or?
No, it's for just something completely different. Not about me. I'm just a witness.
You just said student conference call, so. But then you guys talked about that. Somebody pushed the wrong bit.
All of you guys are just huge liability.
Yeah.
We really are that.
Happy? Sounds good.
Yeah, me too. I think I'm safe. I can only think of a handful of times where I've had a weekend.
That's another cool.